really what we wanted to do was change that culture. We wanted to be preventative and proactive.
Welcome to Key into Quality, the Mayo Clinic podcast where we explore the people, practices, and principles that elevate healthcare quality and safety. Thanks a lot for joining us, and a special shout out to our Mayo Clinic Care Network. I'm Dr. Tim Morgenthaler, a professor of medicine here at the Mayo Clinic and a vice chair of Mayo Clinic Quality. And today, we're exploring a hidden driver of hospital safety event that often goes unrecognized, delirium. Co-hosting with me today is Sherry Nemec. Sherry?
Hi, everyone. I'm Sherry Nemec, Consultation Relationship Manager for Quality at Mayo Clinic. Yeah, and I've had some pre-conversations with parts of this team, and I'm really looking forward to exploring this topic more and finding out what our Arizona colleagues have been engaged in.
Yeah, we're talking about something today that can be pretty easy to miss if you're not heavily involved in it, but it's impossible to ignore once you've seen it up close. Delirium can turn a very calm hospital room into a scene of confusion, fear, or even violence. And not because the patient means harm, but because, well, their brain is in crisis. One team, working to make their hospital safer for staff, realized that many of these moments had a common thread: delirium. And what they did next, I think, is a story of insight, compassion, and a commitment to doing better for everyone at the bedside. So let's get started. Our guests today are Beth Terrio, who's a patient safety specialist from Mayo Clinic in Arizona, and Chris Scheuler, who's the manager for the Mayo Clinic Arizona Workplace Violence Prevention Program. Beth, why don't you just tell us a little bit about yourself? Welcome to our show, and thanks so much for being here.
Thank you for having me. I've been with Mayo Clinic for 25 years this year. Started out as a social worker and then moved over to patient safety and quality in 2016. And this workplace violence project, I'm going to talk about the history of this work, is one of the first big projects that I took on as a patient safety specialist.
Wonderful. We're so glad to have you here. And Chris, tell us a bit about yourself.
Thank you, Dr. Morgenthaler. Great to be here. My name is Chris Scheuler. Like you mentioned, I'm the Workplace Violence Program Manager in Arizona. That job basically entails coordinating all of our efforts here to have a safe environment for our patients and staff and visitors, including some of the projects we're going to talk about today and things we're working on. But really, my background was in healthcare security, and before that, federal law enforcement. But I'm really excited to talk about some of the medical things that are happening in the hospital today. So thank you for having me.
Just before we get into the questions, I just have to tell you, you guys put a smile on my face, because if you really think about, you two are here, you're going to talk about violence in the workplace and about delirium. And boy, one of you has a background in social work before they came into patient safety, and the other one in security measures. In healthcare, it's just so fun to have this village of people who come around to health. So again, I'm excited to see you. Chris, maybe you could tell us why you first got interested in this problem. How did you begin to envision how you would deal with it, and how did it all start?
Yeah, so thank you. Really what happened was I actually going to defer to Beth, because she was the one who started collecting the data that really led us down this path to where we are today. So I was brought to Mayo Clinic as a workplace violence prevention program manager. That role didn't exist anywhere. And that was based on a lot of Beth and her team's work on how to identify these problems and what we were looking at. So maybe Beth, if you don't mind, you could talk about where you started with reporting and data accuracy and how you guys first understood that confusion was an issue.
I think it's really a story of curiosity, to be honest with you. So the origins of the work go back to 2018. We did have a violence prevention mitigation committee here in Arizona that I was a part of. It was a newer committee that was identified with looking at workplace violence and looking at possible interventions. And during the meeting, security would be reporting out on events that they were involved in. But I noted, as a patient safety specialist, they weren't reporting on the same events or the same number of events that I was seeing and looking at our patient safety reports. So I also noted during our meetings that occupational health was reporting out on staff injuries from violent patients, and that was going into a completely separate system. My colleagues in risk management were also getting calls on these types of events. So I became concerned and curious that we weren't really capturing all the potential workplace violence events here in Arizona. So I did a deeper dive. I obtained the events for 2016 and 2017 from security, my reporting system, risk management, occupational health, And we established that we'd seen a 97% increase in events over that time period. Yeah. So as anticipated, the number of events was much larger than what was just being reported out by security. So the impact of that was that it really changed how we tracked and reported our workplace violence events. And I took on the manual management of that data, entering from the disparate reporting systems into basically one Excel spreadsheet. And we used it to track the type of event, the location of the event, which system it had been reported into, if there was any staff harm, and if the patient was confused. From the beginning, we really felt it was important to capture whether or not the patient was confused at the time of the event. And that was a manual process. I did have to go into the chart, look at the event and go on the chart and see if the patient was identified as being confused at the time. I wish I could say that we did that. We were like prescient, looking at it, saying, oh, we're going to be able to impact this someday and be very proactive about it. At the time, it was really more wanting to understand how many patients were intentionally harming our staff. We really wanted to capture that group that knew what they were doing and were intentionally being verbally abusive or assaulting our staff. Because of the number of events we saw and that year-to-year increase, in addition to 2 violent patient events that unfortunately led to some serious staff harm, and just our overall concern about staff safety and the impact on the staff, Quality and Patient Safety did seek and obtain approval to do a proactive risk assessment, and that was focused on management of these types of events. And the outcome was including recommendations for training and education, a response team, and the establishments of our workplace violence program. And then the need for those interventions were also reinforced when the Joint Commission released their workplace violence standards in 2022.
Wow. So reflecting on what you answered, it sounds like you drifted into this work just by virtue of your cross-functional efforts. You know, you happen to sit on several different teams in your roles and role in patient safety. And then you explained that it's your curiosity got piqued because you were beginning to notice some of the same actors or same events being reported in different systems. One of the things that you said that's very important is just how siloed these different reporting systems can be. And so it really sounds like it might take somebody like you who sits in on one or more of these committees to begin to see the patterns there. And then somehow you managed to roll up your shirt sleeves and do this deeper dive. And that was a lot of manual work. What are your thoughts about why these data systems are as siloed as they are? Is it just an accident of who gets interested in something and they keep their own database, or are there perhaps legislative or legal reasons why they are kept separate?
I believe it's more just the siloed work. Like everybody owned their own piece of it. So like Brock Health, like they really owned that staff injury piece, right? If staff came and reported that. For patient safety, it really was determined later on that that shouldn't even be entered into the patient safety system. But back then we had MIDAS, and I think that just without having any place else to report it, that was by default where a lot of it was going. And because security was really being underutilized, they were only capturing events that they were called to. And those were events that we ended up identifying were really serious events. Like they weren't being called proactively. It was usually when all else failed that security was being called in. So relying on their data, we were just getting a really small piece of the pie. I would like to say that we've made improvements in that disparate reporting system challenge. We have, in terms of it not being a manual process anymore and pulling the data out. But to date, we still have multiple different reporting systems that capture these events.
So Chris, Beth, and Arizona team have done this great work. They've collected this data, done the risk assessment. What was the organizational response to the findings of that assessment?
Yeah, thanks, Sherry. So really what happened was they decided they needed to get a workplace violence prevention program. And coincidentally or fortuitously, Joint Commission had come out with new standards in 2021 and end of 2021, starting in 2022, that mandated that hospitals had a workplace violence prevention program, a plan, a designated individual. So it all kind of came together around that time. So I did come over from a different healthcare organization, took on that role in January of 2022. And one of the first things I did, I knew that collaboration between all these teams needed to continue, but it wasn't as organized as we probably would have liked. So we reorganized the program. We created a workplace violence prevention subcommittee, which brought in leadership level folks from all around both campuses in Arizona. And then we built our program based on the threats that we recognized, which involved going through every single physical assault that happened in Arizona and reviewing those. And once we did that, we saw these trends emerge. We figured out that there is a confused patient assault pattern that we identified. We also knew that the most common characteristic of workplace violence perpetrators are patients on staff, and it's patients with an altered mental status. So the big drivers are dementia, delirium, some kind of substance intoxication or withdrawal, and then a decompensated mental illness might be the other driver. But really what we saw in Arizona was the confusion, the delirium and dementia were the main drivers. And this assault pattern we recognized really was a cultural thing. It was a very reactive thing. We would see a patient start to have confusion and start to get agitated, and the nursing staff would try to manage it. And they would call the doctor on occasion. They might get a psychiatry consult. They may do some medication changes, but really, or get a sitter or get a video monitoring unit. There were some things done to try to help alleviate the agitation. But what we saw was it generally got worse to the point where the patient was starting to pull out their lines and get very verbally abusive, try to get out of bed. And that's when the staff would rush in because they were very concerned about harm to the patient, which is what their duty is as a caregiver. So they would put themselves in proximity of this patient who's very agitated and angry, and then we would have a lot of assaults. And they were not typically significant injuries to our staff. And they knew these patients didn't have the malice or the mental capacity to understand the seriousness of their actions or the intent. So they wouldn't necessarily report it, and they would endure it. Or it would be bad enough where they would hit a panic button and have security come up because it had gotten out of control. So it was very reactive. And so really what we wanted to do was change that culture and look at it from like a preventative medicine was a big trend. And instead of waiting for something to progress and then treat it, we wanted to be preventative and proactive. We created an assault prevention model, which basically had 4 steps. It was recognize your warning signs, your situation awareness, know what's leading up to these events, and then knowing what your resources are, gathering those, and getting a team together to make a plan. And once you make that plan, this was a big key, communicate that plan to everyone who needs it, whether it's the next shift, whether it's the person coming in to take blood, whether it's the physical therapist, the EVS person, everyone involved in that ecosystem needed to be on the same page, understand what's going on with this patient and how to manage them. So that's really kind of where we landed with that proactive risk assessment and with our program. And we really, really wanted to focus on being preventative and being proactive and being innovative, because when we looked around and we did our research and we benchmarked, we realized that the model was the model I described. It's very wait for it to be out of control and hit a panic button. And we knew that wasn't serving our staff or our patients very well.
Chris, you mentioned something I think is so true in healthcare workers, when we're dealing with patients who are ill, particularly when they're delirious or confused. We do understand that they're not necessarily trying to harm us. We want to help them, and that sometimes gets us in the way. There are some cultural issues. I wonder, maybe Beth, could you just discuss what your views are on the cultural barriers or challenges in healthcare that kind of contribute to the rise in confusion-related assaults on staff?
Sure. I mean, we identified early on in our project that the culture was a huge impact and a barrier on the reaction and the response. When we conducted our focus group and worked with our stakeholders, we just overwhelmingly heard, it's just part of my job. If I reported every time something like this happened, I'd be reporting all day. And it didn't really matter what they were experiencing. It was, we heard about staff being and read about staff being yelled at, kicked, pushed and punched, and urinals being thrown at them. And really the overwhelming thought process was, it's part of my job. It's a bad shift. I'm going to shake it off and go home. The problem is that especially that was downplayed if it was a confused patient. right? So then if it's a confused patient, the staff saying, well, not, they didn't know what they were doing. They had no control over what they were doing. They couldn't help it. And as Chris alluded to, that really impacted their response. So it impacted their reporting it to their leadership. It impacted handoffs to oncoming staff. It impacted calling security. Again, kind of letting things go to the last minute until it was just really so unmanageable. They had to, have a big response. So that was, something we definitely wanted to shift the culture on. That part of what we would tell the staff is this is not part of your job. If that became part of the statement for our work is no, this is not part of your job. But I think also what impacted it, and this is probably true of all healthcare, is that the staff did not know if their employment would be at risk, depending on how they responded. So if they defend themselves, like if I get hit or kicked and I push back, or am I going to lose my job? Am I going to end up having some kind of disciplinary action? Also, what if they didn't provide care because they were being assaulted? We see so many nurses and PCAs that are assaulted trying to prevent assault, or like Chris said, trying to prevent a patient from pulling a line out. They really didn't know, and they couldn't verbalize when their safety should take precedence over patient safety. And how do they make that choice? And we saw that it really caused a lot of moral distress for the staff, just not knowing, not really having a good handle or understanding, or even just having those discussions, right, of when they could back off to protect themselves. And I think it's hard too. Our primary value is the needs of the patient come first. So how do you possibly walk away from that? How do you reconcile that with, if I don't put the needs of the patient first, I may go home with an injury?
Thanks so much for giving voice to those very complicated emotions. I know I've personally felt them as a physician practicing in the hospital and intensive care unit in times gone by. It does strike me it's a bit of what we sometimes call pseudo normalization. That's I just accept that that's part of the job. And if I can just reflect for a moment, I remember way back when I started my training, we would put central lines in without the aid of ultrasound or imaging, and some patients would get a pneumothorax. Hopefully, not too many of them would have that. And it was not unanticipated that there would be an infection. And we kind of, for many years, expected or accepted that as normal until someone gave us a different vision and showed that no, you actually can do it a different way and have that be incredibly rare. So maybe that's kind of the status that this is in right now. You're really trying to create a vision for our coworkers where there is a better way here. We can do better. This doesn't have to be the way it always is. I don't know. Do you think that that's a accurate reflection?
Absolutely. And I think too, we knew we needed to address training and education if we were going to fit the culture. So one of the statistics that we shared in the project when getting approval for the program was that in 2020, only 0.02% of our staff had received any training or education related to managing workplace violence, violent or disruptive patients. So that's changed. And we've seen the staff appreciation and recognition of that, even in our culture of safety survey results. I think that we really just have made a big shift there. But I think the next step is this exciting work being done to be proactive with these confused and delirious patients.
Let's shift into that. So, Chris, how did you take what you learned and begin to create solutions and resources for the staff? And were there any big challenges or barriers you ran into?
Yeah, thanks, Sherry. So what we did originally was, well, like I mentioned, we did reviews of all the cases, and then we put together a team. And then some of these folks were already doing this type of work. So it was more of just getting everybody focused. And coming from the federal government and law enforcement, I loved acronyms. I loved task forces. I did all that stuff my whole life.
You fit right into healthcare then, Chris.
Yeah, so it was perfect that I kind of set it up. Our team is called Impact, Incident Management Prevention and Consultation Team, and it's really a team of multidisciplinary. We have our psychiatry team represented, quality, security, workplace violence, the practice. We have doctors and a nurse on this team, and I'm forgetting some, but we all work together. Oh, care management, social workers, of course, a huge part. So we put this team together to start creating interventions and solutions. And we've done a lot of great work here. But for this particular piece with the delirium and the confusion, we really didn't know how we were doing as far as assessing delirium. And then, we would hear from nurses, yeah, I do my delirium assessment, but then what happens? Nothing. It just goes into Epic, and then there's no follow-up, there's no plan, you don't have anything in place here, and it's nothing. It's very inconsistent. So maybe in one case we'll work together and do well, but in a similar situated patient may not get that same level of support and care. So we started hearing that, and as non-clinicians, I'm not in a position to tell the doctors and nurses how to do that, and I would never do that because they're some of the best in the world. So what we did was we got a lot of physicians and we did a current state assessment with our strategy team. And they went and they looked at the delirium order set. How is that being used? We looked at the delirium assessments. How accurate are they? And are there plans being developed? And we went around the enterprise, not just Arizona. We had a strategy person who helped us with that. Her results we came back with showed that really it's what we felt was happening in Arizona was really happening everywhere. And it's what I mentioned. It's just that inconsistency. There wasn't a formal process. Like I mentioned earlier, it was very reactive in the way we treated this. And a lot of folks weren't even aware of how dangerous delirium is. And so some of that learning was that delirium is a medical emergency, and we don't have the awareness and the resources in place to manage that medical emergency. We know there's things that can be done to reduce delirium or to prevent it. And a lot of our staff weren't aware of those things. And so, I won't get too far into the project and how we did it, but we knew we had to change the way we practice medicine at Mayo Clinic, which is a big, huge undertaking across the enterprise. So we brought in the experts, and we found a nurse scientist in Rochester, Dr. Heidi Lindroth, and she came in and she's one of the top experts in delirium in the country. And she really educated us and gave us a good foundation of understanding what the best practices are for delirium. And then we got a lot of our psychiatry partners, our geriatricians, and some of our internal medicine docs here in Arizona, and they all joined this project team. And we started doing meetings and collaborating with some of the other projects that were going on in Rochester and other places. We knew there was a lot of work going on, but it wasn't organized and it wasn't communicating with each other. So similarly with the silos with reporting, we saw that with the delirium work. So this project's aim was to bring all those teams together, to learn about what everyone's doing, and then kick off this project, which we did. We got to a point where we wanted to pilot it on a unit. So we identified a unit in Arizona because we had so much momentum going here. We wanted to do it locally. A lot of our project people, some of those will be on later podcasts talking about how this project was created and executed. But really, we wanted to do it locally because we knew we had a problem here. 2/3 of our assaults were by confused patients of our staff. And we knew that. And we also knew that we had leadership here who had an appetite for this, that wanted it. And we knew how important that was, because if you're going to manage change, you have to get buy-in. And without leaders buying in, it's super difficult. So that was where we were at. We ended up on 5 East, which is an inpatient unit here in Arizona. They do a lot of transplants, but they also get a lot of HIM hospital patients. So we felt it was a great environment, and so far, so good.
That's wonderful. And Chris, I'm glad you mentioned that about the project and Dr. Lindroth and the next podcast, because we will be having a future conversation with the team to learn, roll up your sleeves, dig in, what are the things that they did. So for those of you who are listening, watch for that one coming up soon.
We're getting close to the end of our time together, but I just wanted to offer up an opportunity. I mean, you two have both described, I think, so many important aspects of just the enterprise of how do we work together to improve quality in healthcare. You've mentioned being curious, you've mentioned listening, you've mentioned teamwork, you've mentioned change management, you've mentioned the key aspects of leadership. We haven't heard the end of this project, but we've heard the beginning of it. Beth or Chris, I just would invite either of you, if you had something to say to other organizations that are listening about how might they start to pull off the decal and start seeing what's underneath it for this type of project. What would you have to say to them?
You start with the data and make sure that you're capturing it from every angle, every potential reporting site, because the data is going to tell its story. The other thing that I would say, I think that really impacted the response to our project and the support, when we For a long time, we would include the staff experience in their own words when we presented the data. So we're just presenting numbers. We were presenting the handful of narratives of what was being reported. It was hard. We did get a little bit of pushback at the beginning that we shouldn't be using those words or maybe talking about these types of situations and meetings. But our thought was, if it's painful to hear or uncomfortable for us to hear it, we need to think about what it's like for the staff to experience it. And I think that was a really good driver for this work, was for us to be a voice for the staff to leadership as to what they were experiencing so we could impact change.
That's spot on as usual. But I would say also, we felt we were unique here at Mayo in Arizona because the average age of someone who commits workplace violence here is 71 years old. That's the average. So we have 100-year-old people committing workplace violence, which seems incredible, but it's true. As most people know, Arizona is a retirement destination state, and we have an aging population here. But I would argue that this is not necessarily just that population. A lot of this delirium is hospital-acquired delirium. It comes from different places in different ways. I mentioned some of the other causes can be, substance abuse or misuse and withdrawal. It could also be other medical conditions, medications, infections. Our transplant population suffers after surgery. You can have delirium. There's a lot of ways delirium shows up. And delirium is terrible for the patient. It's terrible for our staff. It's terrible from a business model for your organization. It's hard for us to discharge these patients to a next level of care because of their behaviors, and they're in restraints or on psych.
Chris, are you sure you don't have a medical background?
I don't. I just talk to a lot of people, a lot.
Thanks so much. And actually, you're absolutely right. On the one hand, I know that Arizona has its own unique population, but even as far back as 2014, I'm just giving one report in the Journal of Hospital Medicine. Hospital system elsewhere, they evaluated what's the association between combative behavior requiring intervention and delirium. And 50% of their general hospital population exhibited delirium prior to an event.
I want to just say that, the culture of healthcare is something that we've taken a very strong look at as far as how do we change the attitudes and practice of our staff. And one of the things we've learned is that a lot of our staff consider the safety of the patient to be the most important thing that they deal with in their care. And then they consider getting a complaint or having a concern raised about their care, or getting fired or getting in trouble. That's their second concern. And then safety is their third concern. So their own safety takes a backseat to these other issues. And it's very hard to be a great nurse or doctor or healthcare giver if you don't feel safe and supported. And so that's some of the culture in healthcare that we're looking to change.
I just think you guys have really brought together for our listeners a very compelling reminder. When we pause to understand the why behind challenging behaviors, a lot of times we can uncover opportunities to improve care, not just for patients, but also for those of us who are caring for them. And that's the trifecta there, right? You get great outcomes and great experiences for those who work there and for the patients who are there trying to receive help. And so, by recognizing delirium is a safety issue, not just a clinical one, I really admire your team that you've turned that data into insight and now the insight into action. Your work is really showing that even deeply ingrained cultural beliefs and challenges like workplace violence can be addressed when we collaborate, ask the right questions, commit to change. I would say to our listeners, if your team is seeing similar patterns, or even if you're not sure, I think today's conversation really offers a starting point. Invite your coworkers to listen in on today's conversation. Take a fresh look at your data. Talk with your frontline staff and consider what steps you might take to protect both your patients and the people who are serving them. Thanks again, everyone. Thank you, Beth and Chris, for your work on behalf of our staff and our patients. And thank you so much for your time today. We really are appreciative of it. For our listeners, thank you for joining us today on Key Into Quality. Until next time, stay curious, stay connected, stay committed to safer, smarter care. Our goal is to improve quality for patients and the populations that we all serve. If you all enjoyed this podcast, we'd be grateful if you left us a review on Apple Podcasts, a rating on Spotify, or feedback wherever it is that you listened. You can follow us on your favorite podcast platform. Also, share this podcast with others in your organization so that the information can be spread. Until next time, goodbye.